Good afternoon. This is Dee Morris and Alice Fanning, and we are here to present our ethics and health policy debate, ethical debate as well, for the 7007 course.
Our ethical issue is genetic testing for disposition in adult onset disease, and we'll be talking about the pediatric population being tested for adult onset diseases. Genetic testing alone is complex with the rapid advances that are going forth in this time, and the endeavor to make it part of our day-to-day clinical practice. One of the top priorities with genetic testing is the informed consent. The clinician must be knowledgeable so that they can provide accurate information to the patient and also be available for any support that the patient may need as far as the results of those tests and the diagnosis. Patients should be informed that genetic testing could reveal that they have are at risk or carry of a specific disease. The results of the testing has important consequences and can lead to difficult choices that they have to make not only for their current health but as well as for the future health, insurance coverage, their career, marriage and family planning, and other reproductive issues. Laws and policies regarding testing of children presents a unique and even more complex issue in regard to counseling and consent. The clinician now has to balance the rights of the child as well as the rights of the parents and the information that they give in order to optimize the ongoing health care of the child with the rights of the parents as the guardians of the child.
Okay. There's several regulations that we found in the literature review, and the one specific to Louisiana, it really protects the patient and regarding the genetic property and who it belongs to. Policy 22-213.7 as well as 40-1299.6. This protects the patient as far as the personal property. The genetic information is that patient and it's not able to be bought or sold to any other company. There are specific penalties for the privacy violations, and there must be a consent to release the information disclosed within that genetic testing result. That's just one of the policies for Louisiana. Back in 2008, the GINA, which is the Genetic Information Non-Discriminatory Act, written and passed by the U.S. Senate, protected the information gathered in the genetic information, and it was later revised into H.R. 493, and it passed the House actually on April 25, 2007. The GINA goes along with the American Disabilities Act, incorporates it as well. The actual bill will prohibit discrimination on the basis of genetic information with respect to health insurance and employment. And we'll talk about this a little bit more in our ethical debate. Also, other congressional activity that we found in review of the literature under the genome.gov would be August 2006, Genomics and Personalized Medicine Act of 2006, and it was introduced by then Senator Barack Obama and Senator Richard Burr. In March 2007, Senator Edward Kennedy and Senator Gordon Smith introduced the Laboratory Test Improvement Act. And then finally, June 2013, Representative Louise Slaughter from New York sent a letter, and it was co-signed by 8 of her colleagues, and it urged the release of the FDA to draft regulations for laboratory-developed diagnostic tests. And as of April 2015, that was the most recent literature there.
For our debate, we will be looking at deontological stance, but before we go into that, we'll look at our ethical principles that we'll look at during our debate. According to Porsche, there are several different ethical principles that we will be looking at. They list in our ethical decision-making process, including beneficence, non-malfeasance, justice, autonomy, and addition to fidelity and veracity. The principles we identified as being most in conflict in our issue are autonomy, which is the respect for a person's right to make their own autonomous decision in their health care, and in this case, the child's autonomy in comparison with the parent's autonomy in regard to their legal responsibilities as the guardian of the child. We also looked at beneficence as one of the ethical principles, where you weigh the benefits against the risk. Time is something that we'll be looking at because with children, without knowing the definite benefits of the child and how it's going to affect them immediately, and looking at the potential future, it could dispose increased risk later on as well as right now at this time. Another ethical principle we'll be looking at is non-malfeasance, which is do no harm. In the respect of a clinician, we have to weigh what's best in the interest of the child against the desires of the parent, and to know what our rights are and our stance as far as professional code of ethics goes when it comes to do no harm.
Okay, so to begin our debate, we're going to talk about the deontological stance, and that will be used as part of the ethical dilemma. According to Porsche in his 2012 edition, the theoretical framework is based on moral obligations. It's based on the motivation behind the action and the moral right and wrongness of it. It addresses the individual's feelings toward the actions based on moral obligations, and their decision making is based on their values, beliefs, and consideration of the norms. It's the ever non-changing. It goes across the board.
When we're looking at, first of all, the pros, or the reason why I feel that we need to have the pediatric testing for adult onset, the first thing I looked at is according to Harder and Chung in 2014. They cite the American College of Medical Genetics in stating that it's in the child's best interest, first of all, because they will have the opportunity, the parents will be able to make the decision to seize the opportunity for the child to have the testing. This is something that the child will have now, and later in life they may not have that opportunity. It may not be of value to them, but while the parent has the opportunity to do the testing, it's something that may be done. I think that was the stance for the American College of Medical Genetics back in 1995. And there may have been some changes now. However, we still have to look at the fact that the opportunity for testing for children is something that we need to look at for them now, because it's going to affect them in their adulthood. But if they know now, it's something that we might be able to introduce some new interventions and some new treatments and some modalities. So having that knowledge would benefit the child. Mm-hmm. So I think it's something they could do now.
Mm-hmm. And looking in the literature, Rawls and others identified that 1995 principle and had realized that with the research that had been done, the advances in the biomedical technologies, more that we know about the genetic testing and how genetic testing is more available and the treatment modalities available now, they recommend that if the child is able to understand and it can affect them now, if there's benefit now, do it. However, we have to consider the child and the informed consent, and also consider the assent. The American Academy of Pediatrics recognizes a child being able to assent at the age of 7, even though that being a very young age. The children, although they can give their assent and their informed consent, it could do some psychological harm to them. There may be a stigma associated with them being diagnosed with or at an increased risk for, say, BRCA or even the Huntington's. And that's something that we need to take into consideration, is how it's going to label them not only psychologically but also medically as well.
Well, that's a good point. However, I think that Rashman in 2013 mentioned that in cases like with the Huntington's disease, there's no actual treatment for it. And in that case, well, no, it may not be something you want to do. However, if you're looking at other diseases that there may be able to benefit, for instance, if in the case of the BRCA, one with the association with breast cancer, you may want to go ahead and have the child tested, because then as they grow into adulthood, you will be more aware of the amount of times they'll need to be screened. You will be more aware of what they may need to do. You can be more proactive with your modalities in things like breast cancer or ovarian cancer. So mammograms and ultrasounds, and if they need to do any kind of prophylactic surgery. So that would be something you might want to look at. Case in point, Angelina Jolie is currently in the media, and she's in the social eye of the public right now. And she had to battle with the BRCA1 as far as breast cancer, and her mom dying at 56 years of age due to cancer. And she opted for mastectomy because she knew she carried the gene. But her biological children were also possibly affected. So at this point, we have to consider, yes, there may be something we can do in going in and getting the testing done now so that we can do what we need to do prior to them coming in as adulthood and having problems later in life.
Mm-hmm. Exactly. And then if we want to consider the genetic predisposition that these children have to adult onset illnesses, it may increase their anxieties. They may say, well, I have this, and what's the point of living, because I know that I'm going to get breast cancer eventually, or that I'm going to get ovarian cancer. So it can really increase the stress of the child, even though they're at the age of ascent and they understand that this is what their increased chance of developing the disease, whether it's the Huntington's or the BRCA or even the Lynch syndrome. That's another genetic one, and even that I'm looking at in my study right now.
Okay. And that may be the case, but like I said, even with that, you still have to look at, if you're going to look at it where we wait, then what's the use of having the prenatal screening? I mean, you'd be looking at basically the same thing. You'd be looking at, okay, that it's not known and anxiety is going to be there, and we're going to look at the parents' anxiety, we're going to look at the child's anxiety. But by the same token, you can have anxiety just because of the family history. By having the child to have the genetic testing done, that may alleviate some of the anxiety, because not all of it would come back positive. Some of it would be negative. Mm-hmm. And if that's the case, you don't have to go through life trying to say, well, my child's going to die at this age because she has this gene or he has that gene. Now you're at a point where you can say, I can alleviate that anxiety because they don't have that gene. Mm-hmm. So that's a possibility.
Mm-hmm. And I'm glad you mentioned the parents' anxieties, because their anxieties actually could go up knowing their child has this. Let's say there's two siblings. One of them tested positive for the gene and the other one did not. Are they going to treat this child different because they're now positive screening and they know the course of this child's potential future health, or is it going to alleviate their anxieties?
Good point in looking at that. But by the same token, I can see the sibling distinction that they may have. But if you're looking at that, it's also going to depend on the parent. Mm-hmm. Are the parent at a level where they can actually handle the mm-hmm. testing? And that's not to say that every family should have the testing for their children for adult onset disease, but those families, and as clinicians, that's where we have to come in at. We have to go in and we have to see what's the status and can the psychological status of the family, the parents, to see if they can handle if there's going to be a negative result. Are you prepared to deal with this? And if so, what is that effect going to be in the case like siblings? Then are you going to be able to treat the children equally and not have your life consumed with the one that may be dying or have this fatal disease? So that's part of the clinician's responsibility as far as being knowledgeable and being there to help the parents to be able to go through those emotional burdens that they may have to carry.
Right, and as we're looking at the parents' anxieties as well as the child anxieties, the Journal of Ethics considered the self-esteem, especially in the young adolescent teenagers when they're looking at potential for breast cancer later on. That's definitely something to consider as well. How vulnerable they are, and maybe even the parents being too overprotective. American Medical Association pointed that out as well.
Yeah. And those are things we may have to consider as well when we're looking at genetic testing, as far as the anxiety of the parent, anxiety of the child. When it comes to insurance as well, you have to look at that. A lot of the people, when you start looking at the various ones, including the American Society of Human Genetics, they look at it and state that there's a lot of things in regard to insurance, that this may be something as far as confidentiality and that type of thing. But one of the things that I found is that the Affordable Care Act actually protects those individuals based on genetic findings when it comes to health insurance. The Genome.gov mentions that the Genetic Information Non-Discriminatory Act of 2008 also protects those individuals with genetic findings against fraud or discrimination based on their health insurance as well. So there's things in place that even if you decided that you wanted to go with the testing in the pediatric population based on looking for adult onset disease, you wouldn't so much have to focus on discrimination from the health insurance aspect, because there are, even though it's relatively new and we're advancing, there are things in place now to protect us.
And just as the GINA, which is the Genetic Information Non-Discriminatory Act, just as it protects them from discrimination and denial of health insurance, it does not protect them from being denied of long-term care insurance or disability insurance or even life insurance. So having a positive genetic screening can eventually catch up with them in the fact that they may not be able to apply or be approved for any of those insurances that we just discussed.
When it comes to insurance and life insurance and health insurance, truly that's something we have to look at. There again, looking at the healthcare provider, then we'll have to go in and say, okay, this is what we have to do. We have to make sure that we thoroughly explain the risks and the benefits. We have to go in and make sure that we explain what they may have to deal with as far as the insurance coverage. We have to explain to them what they may have to go into as far as reproduction and family planning. These are all areas that we as clinicians may have to come into. The other thing is we have to broaden our scope to not only look at the parent and look at the child, but also look at the family. Because if you go in and do the testing for the disposition for the adult onset for the child, then it's also going to affect the family members. If the child comes back positive, then you're still going to have to look at the fact that now the family is aware. And they may be interested in getting screening for that disease as well. So it's not so much just the child and the parents that have to be considered. There are other stakeholders. You also have to consider the family of the child, because, if the child gets tested, which, is something that I think they should have, then the family, aunts, uncles, cousins, they also might want to go in, and it would help to alleviate some of their anxiety in regard to the disease process.
And mention the anxieties. The child may be diagnosed with this, or they have the genetic predisposition that they will develop the adult onset illness. This could increase the anxieties of the aunts or the uncles, the cousins, and they may realize that I don't want to go get this checked. I want to just stay in the dark. If I don't know it, it don't exist. That's the mentality that we also have to consider for the extended family members. It could be beneficial knowing that they have this increased predisposition, but let's think about their psychological and how it could harm them in that way.
There again, a lot of that responsibility is going to come back on the clinician. That's why I feel it is so pertinent and important that when making the decision in regard to testing, genetic testing and predisposition of adult onset diseases, it is necessary for the clinician to come forth with knowledge and knowing exactly what it is they're going to disclose to the patient. But as you're knowledgeable, then you are going to have that patient, parent, child, if, like you said, if they're able to understand, because that's something else that you have to look at. There is a law called the Mature Minor Law that goes into the fact that if the child is capable of understanding, you want to include the child in with the decision-making process. So as a clinician, we need to have that knowledge so that when they come in, we are able to assess not only the child, the parent, and the possibility of them handling the negative, if there's a negative outcome with that genetic testing.
Yeah, and we also have to understand where we stand on our moral grounds. We have to separate what we feel is right and identify what is actually right, weigh the risk and benefits of the patient and their parents. You know, if they're under the age of 7, where they're not able to give their assent, or even older, where they're adolescent and we're thinking about the hormones and all the indecisive they can be, and how their responsibility level. It just depends not so much on the age, but on they're able to understand and comprehend. A teenager that doesn't keep their room cleaned or lose their homework is now making a life decision, and that's something that we may not need to put onto the child right now, because that is a big decision. So, and then also as clinicians, if we're not comfortable discussing genetic counseling and interpreting the results, then maybe it's something that we don't need to approach.
And you're right, which brings us to our ethical decision-making model. Basically, what we're looking at and what we would use for our ethical decision-making would be what we found is our core values model. And the core values is based on, as you can see here, the core, the CO, is for our codes of professional conduct. The R is our regulations, our laws, and our policy. And then the E is our ethical principles, which we've identified as benefits, non-malfeasance, and autonomy. And our values, as Alice was mentioning, our values, not only our values as clinicians, but also the value of the patient, in this case, the pediatric or adolescent or the minor child, and as well as the parent, as well as others like the patient's family. So all of those would be factors that you would have to look at when making the decision as to what we would want to do in regard to minors who would be undergoing genetic testing for adult onset diseases.
And we've also talked about the regulations that are in place, whether it's the Equal Opportunity Act for the employers, where they cannot discriminate against the patient, a minor, whenever they do become old enough to work, cannot discriminate them because they have a genetic disorder. They've been identified as having that predisposition. Also, HIPAA, which has come into play the last 15 years and protects the patient's confidentiality, not only of what they have, but also of their past medical history, cannot be released. Louisiana went a step further and put in regulations to limit where that information would go and how it would be released, and even strong stipulations for any violations in that. Other policies would be the GINA that we talked about earlier, that protecting and making sure there's no genetic discrimination. The other things of codes of professional conduct, we kind of touched on this along the way also, with being comfortable talking to the patients about, and their families, because we are working with minors, but talking to them about the benefits and the risk of having screenings, letting them know of the psychological disadvantages, the insurance disadvantages, also the psychological of the family, all the immediate ones that may also be impacted because of the positive screening. Also, just the health insurance companies, the medical facility, we need to keep those in mind as well.
The model basically, as looking at it as far as coming to ethical decision making and utilizing the model, we've basically looked at various different pros and cons of the genetic testing. What we found out and coming to a resolution is that as practitioners, we must be able to deal with our personal paternalistic emotions and be knowledgeable about the risks, the benefits, and the potential outcomes of any minor testings genetic testings we may do. And each case should be based on its own individual merits according to the severity of the disease, and being able to balance the emotional and cognitive competence of the parent and the child based on not only their psychological status and where they're at that particular time, also looking at the future as well as making sure that we're aware of what the long-term effect may be in regard to the genetic testing.
And looking through the literature, the American Academy of Pediatrics, although at first they considered that it needs to be conducted, 20 years later have since changed that, and they agree with the American Society of Human Genetics, as well as the American College of Medical Genetics Board of Directors. They all agree that if the patient, which is the minor child, can benefit from the genetic testing now, which means that if there's testing and screening that needs to be done now as a child, to go ahead and perform those genetic tests. However, if it's not any screenings or any new treatment changes or treatment modalities that would change the course of the disease, it needs to be put off until the child is an adolescent who can really understand, or even into adulthood. So therefore, after considering the potential risk and benefits, these experts that we mentioned concluded that predictive testing of children for adult onset diseases is not appropriate unless specific medical interventions are recommended prior to adulthood, or there's a request voluntary and comes from a competent and informed adolescent.
So it's a good ethical debate, and the saga continues as we advance in genetic testing. Who knows where this may take us? We look forward to further research. Have a good day.
Thank you.